Good day, everyone, and welcome to ISMP's webinar, Quantifying the Holistic Costs of Controlled Substance Medication Waste. This is the second of 3 programs in a series of medication safety webinars dedicated to drug diversion and patient safety. My name is Chris Mahalik. I am an ISMP pharmacist, and I will be serving as your webinar host for today's program. The availability of opioid medication doses above what is typically prescribed for patients is a known medication safety and diversion risk. A recent study quantified the increased drug and human resource costs associated with waste of excess controlled substances. Today, our speaker team will share practices that impact the safe use of IV medications, interventions to prevent diversion, and quantifiable cost data accounting for workforce, waste, and disposal associated with the waste process for intravenous push controlled substance medications. Next slide, please. Following completion of this activity, participants will be able to identify practices that impact the safe use of IV products in the inpatient setting, discuss interventions designed to detect and prevent diversion, and recite quantifiable cost data accounting for workforce waste and disposal associated with the waste process for IV push controlled substance medications. Our program today is supported by Fresenius Kabi, and I would like to thank them for their generous support. This program is being recorded and it will be available on the ISMP website. Handouts for today's program can be found using the link that was provided in the reminder email that you received earlier today, or you can find the link to the handouts in our Zoom chat box. Please do note that all attendees are in listen mode only during the presentation. Do feel free to ask a question by either using the Q&A or chat box on your toolbar. Before we start, I would like to introduce our 2 speakers today. Our first speaker is an ISMP nurse, Susan Paparella. Susan is a vice president at ISMP and oversees the development and implementation of ISMP's consulting, collaborative, and educational services, including proactive medication safety risk assessments, root cause analyses, practitioner in residence programs, and ISMP's international experience. Susan is a contributor to ISMP's research agenda and has co-led several national safety summits, resulting in the creation of ISMP safe practice guideline documents. In 2012, Susan was awarded a Villanova University College of Nursing Medallion for Distinguished Contributions to Nursing Practice. And in 2016, she was inducted into the Abington-Dixon School of Nursing Hall of Fame. Our second speaker for today's program is Dr. John Hertig. John is vice chair and an associate professor of pharmacy practice in the Butler University College of Pharmacy and Health Sciences. Dr. Hertig lectures around the world and publishes on a variety of patient safety, leadership, administration, and health policy topics. His extensive research program is designed to enhance the safety of the medication use process while using evidence to inform patient advocacy efforts. Dr. Hertig is also a member of the United States Food and Drug Administration Drug Safety and Risk Management Advisory Committee. And in 2018, he was awarded the Alliance for Safe Online Pharmacies Global Patient Safety Champion Award. Complete bios for both of our speakers today are available on the ISMP website. So now, without any further delay, I'd like to welcome Susan. Can we please go to the next slide?
Well, thank you, Chris, and hello, everyone. I'd like to start the conversation today focusing on medication administration practices that not only impact safety, but can contribute to bedside product manipulation, drug waste, and could actually be an open door to controlled substance diversion. Nurses as direct caregivers spend a significant amount of time, up to 25% of their time, in fact, on the critical task of medication administration. Researchers Hendrick and Chow, conducting a 36-hospital time and motion study, suggested that approximately 2/3 of medication administration time is spent on the actual task of administration to the patient, while the other 1/3 of the time is spent gathering and preparing drugs for administration, including diluting and reconstituting drugs or preparing infusions. The recent COVID-19 pandemic and subsequent staff shortages in all departments have presented significant challenges to organizational medication use and associated safety. Hand in hand with drug shortages, these challenges place strain on pharmacy preparation and distribution practices, which can result in a shift of more drug preparation to nurses, increasing the possible impact to efficiency, safety, as well as security and diversion efforts. Next slide, please. We know that IV medications are an essential component of care and are clinically advantageous due to their immediate therapeutic effect. Many high alert medications, including opioids, are administered intravenously, but because these IV medications often have a narrow margin of safety, errors with these drugs associated with a higher risk of patient injury or death. Survey results suggest that clinician-prepared syringe is a common practice. And in the American Nurses Association study, nearly half, or 44% of the nurses, told us that they administer medications via syringe more than 5 times a shift. And about 1/3, or 37%, administer injectable medications at least once a shift. In a 2018 ISMP survey, nurses indicated they do not regularly receive IV push medications in ready-to-administer syringes. In fact, 75% of the respondents in the survey reported that less than half of the time IV push medications are provided in a pharmacy-prepared or commercially available ready-to-administer syringe. Next slide, please. Despite an extensive awareness of the prevalence of substance use disorder in healthcare professionals and data demonstrating that substance misuse is an occupational hazard for healthcare workers and for those in training, little progress has been made to improve the prevalence, education, and outcomes in many organizations. Statistics from the U.S. Substance Abuse and Mental Health Services Administration and the American Nurses Association suggest that about 10% of healthcare workers are abusing drugs. Some believe this number to be underestimated. According to the National State Board of Nursing and the Anesthesia Patient Safety Foundation, it is estimated that 10 to 15% of healthcare workers, including anesthesia providers, will misuse drugs or alcohol at some time during their career. It has been suggested that substance use disorder is the most frequent disabling illness in healthcare workers. We heard in the last webinar about the significant ramifications of drug diversion in both inpatient and ambulatory healthcare settings, including the impact of patient and staff safety, increased costs, and infection outbreaks. Don't be fooled. This problem is real in your organization too. No organization is immune. Healthcare workers who divert can be anyone from new graduates and new employees or agency staff to veteran professionals who are considered high performers. It is time to seriously consider what we can do collectively to reduce the risk for diversion exposure to our patients, staff, and our organizations. Next slide, please. On last week's webinar, Chris and Barb covered a wide range of vulnerabilities that contribute to the ease at which drugs can be diverted. As a brief recap, these include storage vulnerabilities in pharmacy and on clinical units, the number of documentation vulnerabilities, such as access to records after patients are discharged or the ability to create a shadow chart, or the lack of clearly defined organizational expectations or compliance to dedicated policies. We also are concerned about environmental limitations on wasting, not having the disposal containers we need in all areas or the correct size, or not investing in the products that fully destroy or inactivate the drug product to protect against diversion from waste receptacles. But we also must look for more subtle behaviors and practices that can be considered at risk that may signal us that drug diversion may be occurring. These include medications that are removed from stock but never documented as given, drugs removed that never actually reached the patient, either the patient refused or the syringe is broken, or delays in wasting and documenting waste, or using a consistent wasting buddy. Unclear or unstated expectations or non-compliance with drug wasting procedures can also be an at-risk behavior. Is it clear to your staff when waste should occur? Is that upon selection before leaving the ADC or after administration has occurred? Is the wasting a deliberate action with careful review by a second individual? Or is confirming waste done in the same manner we sometimes see practitioner confirm a double check from afar, moving on quickly without clear and deliberate review? Not all of these behaviors will directly result in diversion, but at best, they may be at-risk behaviors that should be investigated and systems adjusted. Another at-risk behavior I would like to spend a bit more time on is the unnecessary manipulation of controlled IV products. Next slide, please. Organizations should re-examine choices that they make that may contribute to the unnecessary manipulation of IV medication occurring outside the pharmacy, and what steps they can take to limit this practice, not only for patient safety, but for diversion prevention efforts as well. These include behaviors and practices which in some cases may be considered the norm, such as using part of a vial or ampule or more than one vial or ampule for a single dose, selecting to use a vial, ampule, or syringe that far exceeds the dose needed, selection and use of a maximum dose for the patient as the initial dose, the need for multiple steps or manipulations to prepare the drug outside of the pharmacy, such as vial to syringe transfer, syringe to syringe transfer, and other forms of dilution. And unnecessary use of concentrated injectable medications for adult patients where further dilution is always required. Due to limited formulations, drug dilution is a fact of life with many of the pediatric doses that we prepare. But when unnecessary manipulation occurs with regularity in adult doses, it is harder to identify if any individuals are diverting medications because this level of unnecessary manipulation then becomes the norm, and diversion can actually be in plain sight. Next slide, please. ISMP has long been concerned about the practices of unnecessary dilution. An initial ISMP survey in 2014 looked at dilution practices with over 1,700 respondents, 97% of them being registered nurses, and they told us that nurses frequently dilute medications during patient care. While we know this practice might be necessary depending on the drug and the dose required, this practice also may be equally result in the unnecessary repackaging of prefilled syringes or other containers that are provided by the pharmacy. And we know from error reports and other studies that unnecessary manipulation can lead to those safety issues such as unlabeled or mislabeled syringes, potential contamination of sterile IV products, dosing errors, and not to mention the additional time required for medication preparation. In this survey, overall, approximately 83% of the nurses that responded to both a 2014 and a repeated 2018 survey told us that they further dilute IV push medications, sometimes, often, or always, for adult patients prior to administration. Here's what we know about those dilution practices. Medications that are available in single dose vials or ampules were most often diluted, 77% of the time, but 14% of respondents said that they always diluted this form of product. As many as 20% further dilute medications from pharmacy dispensed syringes, and 5% said they always diluted these medications. And when asked about the dilution of specific drugs, opioids and anti-anxiety medications were the top drugs that were frequently diluted, but 27% of providers said that they always further diluted the opioids. Next slide, please. The survey also asked if respondents used a standard volume of diluent each time they prepared a specific medication. And about half, or 49%, indicated that the volume of the diluent was often variable, even when preparing the same drug. Respondents were also asked to describe how they determined the volume of diluent to use, which was also highly variable. Many had personal formulas. For example, they might dilute all their drugs in 1 ml, regardless of the volume or concentration of the actual drug, so that they control the time needed to slowly administer the drug over 1 minute. This variation was not surprising when we learned that less than half of respondents, or only 43%, reported any type of organizational policies or guidelines on dilution. Another important finding from the survey was that 81% of practitioners confirmed using commercially available or pharmacy prepared 0.9% sodium chloride flush syringes for drug dilution. This is a practice ISMP has cautioned providers against for several years. Remember that these commercially available products are classified as devices by the FDA, and they have never been tested or approved for drug dilution and subsequent drug administration. Next slide, please. ISMP also conducted a survey of frontline nurses who use carpiject style pre-filled syringe cartridges for injectable medications. At the time of the survey, we were looking at the issue of overfill in these pre-filled syringe systems. But to our surprise, many nurses were not at all concerned about the overfill because they were withdrawing the doses from the cartridges instead of using the syringe. And they were using it like a single or multi-dose vial instead of the pre-filled syringe delivery system. Nurses reported withdrawing all or part of the medication from the cartridge into a syringe before administration, and then often using this new syringe unlabeled. A follow-up about this practice in 2018 told us 2/3 or 66% of participants again reported withdrawing medications from these pre-filled syringes or cartridges and transferring into another syringe. And 16% reported that they do this more than half of the time when they encounter this type of pre-filled syringe. Next slide, please. There were also a number of practices to mention associated with controlled substance infusions that place organizations at increased risk for diversion by healthcare workers. These practices may include the removal of controlled substance infusion bags from secure stock in significant advance of need, often in an attempt to drive efficiencies. In some organizations, we see controlled substance infusions hanging on IV poles outside of lock boxes or secure systems. That concern is not only for the guests and the visitors, but also for healthcare workers who generally have wide range of patient access. Controlled substance tubing with Y-sake connectors that allows for easy manipulation and diversion is something to be concerned about. Controlled substance infusions that are discontinued and remain available at the bedside and are not discarded immediately create a risk for not only for the patient, but also for providers. We've had multiple errors reported to ISMP over the last several years where these products are inadvertently restarted instead of a product that they want to be hanging. So really should be removing those products from the bedside as soon as they're discontinued. And lastly, we have a number of situations where practitioners were compounding controlled substance infusions outside the pharmacy, and sometimes they feel it's necessary because they lack a 24-hour pharmacy support. Next slide, please. Well, I've shared with you some AR examples that have tell us a great deal about the problems of drug manipulation. We want to understand more about the practice of compounding outside the pharmacy. So we did a survey and reported these results back in 2020. Next slide, please. During this survey, we heard from 444 practitioners, 77% were nurses, which included some advanced practice nurses, anesthesia providers, including CRNAs and anesthesiologists. And then the remaining respondents included decentralized pharmacists and technicians who prepare and admix medications and infusions in clinical locations, as well as physicians and supervisors. Most of the survey respondents, or 81%, worked in acute care or specialty hospitals, while others worked in ambulatory surgery centers, ambulatory infusion centers, physician practice settings, or clinics, and as well as long-term care. Next slide, please. So here's what we learned. When we asked these respondents, how often do you mix the following type of sterile injectable medications and or infusions outside the pharmacy? The results told us that 58% were reported that they often or always prepare IV push medications outside of the pharmacy. 53% say they often or always are mixing IV intermittent infusions, many being mini bag diluent containers with that integral vial adapter like the mini bag plus. And 39% report often or always mixing IM injections. So it's good to see that while 52% report never or rarely preparing IV continuous infusions on the clinical unit. 28% often or always prepare this type of parenteral injection product in their clinical setting. Respondents who reported always or often preparing or admixing epidural and neuraxial injections or infusions, 7%, were mostly anesthesia providers and advanced practice nurses and pharmacists, although surprisingly, more than 1/4 of these respondents were actually nurses. Next slide, please. 81% of respondents report that preparation and admixture occurs in less than ideal conditions, such as at the bedside, on the counter in a nurse's station, or on a computer workstation. 35% of the respondents told us that their institution requires an independent double check of certain sterile injectable medications or infusions that have been prepared or admixed outside the pharmacy. And 30% reported this double check for high alert medications, including opioids. We know too that of the IV push medications, most medications that were transferred from vials and syringes included opioids, antiemetics, antibiotics, and proton pump inhibitors. Next slide, please. So in summation of that survey, we know that preparation and admixture of sterile injectable medications or infusions outside the pharmacy is variable and occurs frequently. While I've always thought that the added errors of infection control during compounding and manipulation of the product, it's important that we do not lose sight of the heightened risk and opportunities for diversion when products are unnecessarily manipulated. Next slide, please. So what are those key strategies to reduce the risk associated with manipulation? One of the best strategies is having commercially prepared or pharmacy prepared product that's labeled with a barcode and ready to use to minimize the need for practitioner manipulation outside of the pharmacy sterile compounding area. Providing IV push medications in this ready-to-administer form avoids the unnecessary error-prone complexity of IV push medication preparation and administration, and avoids the risk of contamination of the drug, promoting efficiencies in the medication administration process, and certainly reducing the opportunity for diversion. Next slide, please. Other strategies to support safe IV push medication use that will limit unnecessary product manipulation include having clear organizational expectations that IV push medications are not withdrawn from commercially available cartridge-type syringes into any other syringe for administration, and incorporating standards of practice for IV push medication preparation that give clear expectations about which drugs really need to be diluted and how they are to be diluted, and certainly not using commercially available 0.9% sodium chloride flush syringes to dilute or reconstitute IV push medications. Help nurses and other practitioners see this risk. Next slide, please. Other key risk reduction strategies to identify and decrease the risk of IV infusion manipulation and possible diversion activities include limiting access. Seriously consider if access is needed to all products and concentrations on clinical units. It goes without saying that controlled substances should be in locked lidded compartments or in physically separate compartments and not in matrix or tower storage configurations. Consider the routine manual count of your automated dispensing systems, as well as spot checks, and certainly have immediate follow-up for identified cabinet discrepancies. It's very disheartening to see discrepancies that remain on cabinets for days at a time. Track controlled substance infusions that are removed on override in the ADCs, and don't forget about refrigerated products. Avoid unnecessary handoffs between providers and always follow good chain of custody practices. You can remove controlled substance infusions from the patient room when discontinued and proceed immediately with waste procedures and documentation. Nothing's more concerning than a big gap in time and missing drug. Use lockboxes or physical systems to tamper evident controls that do not allow the practitioner or patient access to the drug chamber, or use products that makes the manipulation more evident. Increase your index of suspicion when the drug volume changes in an unsecured controlled substance infusion. Clearly define those expectations for controlled substance waste that's applicable to all providers in the organization, and reconcile documented waste from IV infusion, starting with the order, through the ADC removal and the doses that are administered and documented in the EHR. Remember, setting clear expectations for organizational controlled substance management, limiting opportunity and expectations for bedside drug manipulation, and closely managing custody and monitoring waste procedures can be an important part of diversion management. So now I'd like to turn this presentation over to Dr. John Hertig.
Thank you, Sue. You did such a nice job describing those practices and risks related to and contributing to drug diversion, and I appreciate that. Hello, everyone. It's an absolute pleasure to be with you on the webinar today. And as we go to the next slide, I think this will help frame the conversation that will form the second part of our webinar today, where we're going to be talking about diversion, detection, prevention, and then leveraging current literature to help support either the establishment or growth of drug diversion prevention programs at your own facility. And I'd like to orient everyone to this quote. If you haven't seen it, it's one of my favorites related to drug diversion. Quote, "If you haven't caught anyone, you may not be looking hard enough." As we've seen in Sue's presentation, drug diversion and risks associated with drug diversion in our healthcare facilities is pervasive. It does happen. It happens a lot, and it likely happens where you work. So we need to do a little bit better job at detecting and preventing drug diversion, first and foremost, to protect our patients as a patient safety issue, but also to help our colleagues navigate really complex mental health, addiction, and other related issues. Next slide, please. Our healthcare system is complex, and so are the common points and methods of drug diversion, starting with procurement, where we have purchase orders that may be removed, therefore scraping them or removing them from the record. Stolen DEA 222 forms, those 222 forms used to order or transfer C2s can be stolen related to procurement. In the dispensing step of our medication use system, we have products that are replaced with other products. So they may have stolen a controlled substance and completely replaced that product with another, or perhaps removed volume from a pre-mixed infusion and then re-injected, say, normal saline or another product to mask the fact that that volume was removed. If we move to the prescribing phase of our medication use process, we have many examples of forged or otherwise stolen prescription pads. Verbal orders, which we know to guard against in practice, can be used when they're not verified to potentially divert controlled substances. Moving from prescribing into the all-important administration step that Sue did such a nice job outlining, there are many instances and opportunities to divert controlled substances. For example, medications documented as given but diverted. Say a patient really needs 4 milligrams of morphine, but that provider or nurse only gives 2 milligrams of morphine. Now you've not controlled or adequately controlled that patient's pain, but you've also contributed to diversion. And then the waste. And we're going to have a greater discussion about waste later in this presentation. But waste in a healthcare facility is an opportunity to divert. The lower the amount of waste, limit the amount of waste, and we're limiting the diversion opportunity. That waste step is not only important for compliance, but if you're not witnessing that waste, you can potentially divert that waste. So speaking more of waste, it's not just waste of products that are given, it's also expired drugs that can be wasted and diverted, or waste removed from the actual waste container itself. There are many examples and opportunities to divert waste, and that's why we're going to have a detailed conversation around limiting the amount of waste floating around our healthcare facilities. In a really bizarre example that I'll borrow from one of my good friends and colleagues, that he ended up being involved in a case of what he called the grape lady. And what the grape lady did, it was a nurse at a particular facility that was diverting hydromorphone. And they were diverting hydromorphone by injecting grapes with injectable hydromorphone. And then that particular nurse was dosing herself throughout the day by eating these enlarged grapes that actually contained hydromorphone. Unfortunately, this is a mental health issue, it's an addiction issue, and there's no lack of clever people determining new and different and bizarre ways to divert product. Next slide, please. Given the complexity of our medication use system, given the fact there are these multimodal points of potential diversion, it's really important that we incorporate various elements in a comprehensive controlled substance diversion prevention program. And that operationalization of an institutional-wide program does require multidisciplinary collaboration in addition to the incorporation of various elements. And I've listed just a few on this slide, starting with our technology, our automated dispensing or distribution machines, our ADCs or ADMs, making sure that those are used in the right way, as Sue outlined, that they're not only there for storage, but also a potential source of data as we look at potential variances for different providers. Secure waste bins, making sure we have them, that they are secured, that they are used to waste product in a secure fashion. Like any important project in our healthcare community, it needs to be interdepartmental and multidisciplinary. This isn't just a nursing issue, it's not just a pharmacy issue, it's a healthcare issue, and not just clinical areas, but also incorporating our human resources group, our information technology group, as well as our related engineering groups. Once you have a good program in place, we want to make sure that we're educating our staff on how to detect diversion themselves, but also how to report and mitigate any diversion. Interestingly enough, in talking with another colleague, we need to be thoughtful about how we educate on diversion detection. There are some great examples of star pupils when these education sessions are going on, these nurses or pharmacists or physicians that are asking a lot of questions and really digging into the methods of how diversion is detected, and then turning around, and those are the individuals actually doing the diversion. So they were trying to learn as much as they could. They seemed like star candidates, but they were the ones that were trying to game the system, and they were doing so by learning as much as they could about the system itself. Because of the complexity, it is important and really preferred to have a medication diversion prevention coordinator, someone who can really see all these various elements in a holistic fashion and put them together in a coordinated way. Oftentimes that does require support from leadership, and having significant leadership engagement that often may include a return on investment or ROI analysis is vital to the long-term success of diversion detection and prevention strategies. There is a significant ROI or return on investment associated with this, meaning that it does require investment, but you will get a lot in return. We'll talk about a few of those costs that will hopefully be reduced with good diversion prevention. But then we have the societal costs. We have costs to reputation. We have litigation costs, and there is a laundry list of healthcare facilities that have had to pay substantial sums because they didn't have a good diversion prevention and detection program in place. There are a lot of best practices, and I don't have, unfortunately, enough time to go through all of them as part of our webinar today, but there are lots of best practices when it comes to detection and prevention of diversion. One of the ones I want to call out as a potential forward-looking option was described by Knight and colleagues in an article published this year, where they learned and used machine learning analytics. And when they used these machine learning data analytic tools, they actually detected known diversion cases in a blinded way faster than our existing monitoring programs. So what that tells me is that we're going to have a lot more opportunities on the horizon to use information, to use data in a thoughtful way, turning that data into evidence to help us hopefully be more proactive with our diversion detection. Ultimately, that's good for a variety of reasons. First and foremost, it protects our patients because we don't want people who are diverting to negatively impact patient care, but hopefully helps us intervene with that colleague or that person quicker, and hopefully saves organizational issues, reputation, et cetera. Next slide, please. Now that we've talked about the medication use system, the various points of diversion, the various elements that may be incorporated, I do want to go through a framework here of how you might set up or expand your own detection and prevention program. And it all starts, like many of our other projects, with obtaining executive support. We have to do this with leadership support. It has to be a priority for our organization. And then build the funding, build the support, build the staff, build the committee off of that executive support. So once you've obtained that executive support, potentially with an ROI, then you're going to want to create a drug diversion committee. And as you can imagine, that drug diversion committee needs to be diverse. It needs to include the necessary stakeholders, not just pharmacy group, not just the nursing group, physician group, but also those other players, including human resources and potentially IT. Once we have that drug diversion committee set up, we're going to do a great job focusing on training staff to identify diversion, being our eyes and ears on the front line. This is the see something, say something approach, making sure that our colleagues are attuned to what's going on in their individual areas. This is sensitive stuff. This is a sensitive issue. It does often involve people that we know well and unfortunately are suffering for some reason from a mental health or addiction issue. So having reporting be anonymous, creating a structure where they can report anonymously and then we can quickly act on it is going to be an essential part of any detection and prevention program. Being proactive is key, and oftentimes we lean on our technology to monitor actively and proactively to address diversion as quickly as possible. And there are some great technologies out there, a lot of great vendors who are leveraging technology to help us get better at proactively identifying issues before they actually reach the patient. Then providing rehabilitation. I think that again, we want to make sure that we're thoughtful in our approach to addressing drug diversion, first and foremost, making sure that it's not impacting the patient. But if it is a situation where we can help a colleague, being thoughtful around the mental health considerations, as well as the addiction issues is important. So having those rehabilitation resources for employees is an essential part of any good detection and prevention program. And like anything else we do in healthcare, like anything else we do in patient safety, we're always learning, we're always getting better. So incorporating lessons learned as part of any program is that last step, which then feeds in to this cycle of improvement as we refine our programs. Next slide, please. Speaking of refining our programs and thinking through making sure that we have the necessary core elements, I want to review this slide, which I really like, and it's adapted from the ASHP guidelines on preventing diversion of controlled substances. This is from the 2017 version. I do know that the ASHP group that came up with the 2017 version is in the process of revising this, and it should be available any day now as an update. So just keep that in mind as I'm going through this, as there should be an updated version available soon. But it does involve a few essential and core elements, starting from those administrative core elements to system level controls to provider level controls. And if we start with that administrative element, again, I think first and foremost, organizational oversight and accountability is key. Leaders need to own this as a major issue, not only patient safety issue, but also organizational reputation issue. Once we do that, we can go down to our system level controls where we have a solid HR management foundation. They're included on the drug diversion committee. The communication pathways are there with our HR team to provide support to those involved in diversion. We have to use and leverage our automation and technology. That could be our automated dispensing cabinets or machines. It could be proactive tools. It could be analytics, but making sure that if we have it, we're using it. And if we need it, we install it. And that will help bolster our monitoring and surveillance programs and ultimately help with investigation and reporting. Going to our provider level controls, chain of custody, having solid policies and procedures that outline chain of custody, including storage and security. And again, hopefully you're building on that technology and using some of the available technology to help with both storage and security. Sue went over some of these internal pharmacy controls. These are controls that are within the pharmacy department that we have a little bit more ability to manage, including some of the storage and security, including some of the policy and procedure work, but also things like matching product with practice. I mentioned that the less waste that's floating around our health system, the less opportunity to divert that waste. And so if we can match what's available via what's actually used and limit waste, that's going to limit that opportunity to divert. And we need to work closely with our prescribers, our industry partners, as well as others involved on that committee in making sure that we match product with practice, ultimately reducing the need to return, ultimately reducing the need to waste and dispose. But speaking of waste and disposal, next slide, please. I do want to go into a more detailed conversation about the medication waste problem because it does impact so many within the healthcare environment, from our technicians to our nurses, anesthesiologists, physicians, pharmacy directors, nursing leaders. Waste really negatively impacts staff productivity and increases overall waste expense or labor expense, adversely impacting patient care. And why does it do that? If we go to the next slide, we'll use some of the more high volume use areas as an example. And if we look at medication use in, say, our ORs or procedural areas, medication errors in these areas have long been known to be especially problematic, including waste. And this is for a variety of reasons. This is often known, these procedural areas or ORs, as the pharmacy black hole, right? We don't always have, as a pharmacy department, a great handle on what's going on. And you couple that with the fact that oftentimes an anesthesia provider is the only person involved in the entire process. So from prescribing to formulating, dispensing, administering, it's only one person. And that removes a lot of the protections of the double checks and other checks and balances that we have in other hospital areas. If you look at one comprehensive expert review paper, this paper evaluated 138 recommendations to determine how to make it safer. And this included, in the highest ranked out of those 138, included standardization, which we know works, written policies for medication safety, which is good only if you follow them, right? And then the use of pre-filled products whenever possible, because we know that pre-filled products, especially manufacturer-prepared pre-filled products, are the safest possible option. Another study looked at data collected on over 13,000 drug syringes and found significant waste that varied from 7.8% waste all the way to over 85% of these products being wasted. The mean waste in this study was 38%. And one of the quotes that stood out to me in this paper was this, quote, "The overall extent of drug wastage in ORs and ICUs is concerning," and it is concerning, especially when we look at controlled substance products. So if we look at the next slide and we talk specifically about controlled substance waste, no surprise here, due to high abuse and diversion risk, there are laws and best practices that dictate how we dispose of controlled substances. It must occur immediately with documentation witnessed by 2 health professionals. That helps us achieve compliance. But that compliance requires time and resources, right? That wasting process to begin with takes that nurse or that individual away from patient care activities, and then you need a second person to witness it. That's pulling additional workforce resource away. Now, although modeling published in previous research found significant costs associated with the disposal of the product, there hasn't been a lot of work around, well, yes, I know we're wasting actual drug, but what are the other financial and workforce costs associated with waste in the inpatient setting? There are really limited direct observation studies related to that question. So if we go to the next slide, enter in my work. And this is work that I did with my research team. The title of this study was a continuous observation workflow time study to assess intravenous push waste. And if you go to the next slide, you'll note that we're trying to address that question, that gap in the literature. And so the primary objective was to quantify the total waste associated with administering. We picked 3 controlled substances, fentanyl, hydromorphone, and morphine, via the intravenous push waste. And we're trying to evaluate 2 distinct categories of waste. One was the quantity of drug. So this is the quantity of medication disposed, otherwise known as the pharmaceutical product waste, abbreviated to PW. The other was the people, the workforce time actually associated with being compliant with that waste disposal process. That's known as the workforce time waste, or WTW. Some secondary objectives, we collected the number of distractions and average time to document the waste. As we all know, oftentimes a product, it should be wasted right away, but ends up floating around the facility, maybe in pockets, maybe misplaced. So we're really curious to get, well, what's the average time to actually document it? Now, to achieve those study objectives, if you go to the next slide, we employed the following methods. It was a workflow time study designed. A data collection tool was developed and used by researchers to capture information in real time. So we had researchers, members of my research team, actually on the units with stopwatches, observing this all in real time to collect these study measures. As mentioned before, we collected those 3 drugs, the product waste amount, the time spent wasting it, that WTW, and then we applied cost models. So cost and AWP was applied to the medicines, and then time cost related to the workforce time waste was used via the Bureau of Labor Statistics salary data. Now, the reason we used AWP is we wanted to compare our work to previous work that had been done using AWP. There are other cost metrics that can be used, but we chose AWP for comparison purposes. Now, if you go to the next slide, I want to talk a little bit about some of the results from our work. In total, we had 669 distinct waste observations that met inclusion criteria. This was collected over 15 days across 4 units at 2 different hospitals, in total representing 80 beds. In total, 207 milligrams of hydromorphone and just shy of 18,000 micrograms of fentanyl were wasted during this 15-day period of time, representing 80 beds. Now, you'll note there wasn't a whole lot of morphine wasted, and we had to go back and look at that. And what we found out is on those 4 units that we chose by happenstance is that the product availability, 2 milligram morphine, was exactly what was on the order sets in those units. And so what was available from the pharmacy and what was on the order set matched perfectly. We had very few instances of waste, which I think, again, reinforces that message of matching product with practice. So that's the amount of drug wasted. What about our workforce time associated with the wasting process? We found that nursing time totaled just over 50,000 seconds, but just to convert that, that's about just over 14 hours of nursing time just associated with wasting process. And that's just in 15 days. Next slide, please, to further elucidate some of the results. And looking at some of the cost information, if you do a per dose calculation, we found that the average total cost per dose was $2.40 for all medications. That means every time someone removed one of those 3 products from the ADC, automated dispensing cabinet, they were essentially wasting $2.40. When a yearly extrapolation model is applied, the total waste was over $35,000 for that 80 beds. Other notable observations worth sharing, 86 of the 669 wastes were interrupted in some way. That, for me, is a patient safety issue. That could also be a diversion issue because you were wasting, and then it was interrupted, which could lead to some other potential patient safety or diversion issues. Of note, the average time to chart waste was 2 hours, over 2 hours, and 31 of those were documented more than 8 hours. And some of the data I didn't include here, but if you actually look at a model of when the majority of the wasting was documented, there are 2 huge spikes for every 24-hour period of time, and those 2 huge spikes occurred at shift change. So notably, a lot of these controlled substances were in pockets or floating around the hospital and being wasted when shift change was occurring. To me, that represents a compliance issue. To me, that's a diversion issue. That's certainly not a best practice. Next slide, please. If you were to do this at your own facility, and I really encourage you to look at waste in your own facility, not only because I think it will help optimize the use of the resources that you have, but it will in turn also limit your diversion risk, is to go look at your own data. So leverage reports that capture actual volumes of dispense of your own data and at your facility. And you may want to start with the medicines that we chose, fentanyl, morphine, and hydromorphone. There may be other medications that you feel like have potential to reduce waste by optimizing the product versus the practice. So identify that, then identify how much it costs, right? Using that AWP data or maybe another financial metric from historic purchasing data, but make sure you include all costs. And I don't think that everyone has the time to walk around and shadow individuals with a stopwatch. So if you want to borrow from my study and look at how much we found that workforce cost to be, you'll know it was about 73 cents per wasting observation was associated with the workforce cost. So you can kind of do your rough calculation yourself to begin to determine how much am I actually wasting in my facility. Next slide, please. But importantly, there are other costs that we didn't include in our study as we're looking at diversion prevention and waste prevention. And one of those were the costs associated with disposal. As many of us are aware, during the pandemic, right in the middle, in August of 2020, the EPA banned the sewering of controlled substance medicines. And that comes from the Federal Resource Conservation and Recovery Act, or RCRA. Controlled substances must be rendered irretrievable if any wastes exist after administration. And so to combat this or comply, healthcare facilities have had to purchase controlled substance waste disposal bins, which obviously have a cost associated with them. No longer can we use the antiquated method of free sewering down the sink. That is no longer acceptable. So these prescription waste disposal systems add recurrent costs that must be factored in. The more waste, the quicker these bins get filled. The more the bins get filled, the more we have to pay for them. So if we limit our waste, we're going to limit the use of these bins in addition to the other costs as described. Speaking of other costs as described, going on to the next slide, there are other costs that you can certainly consider as part of any return on investment calculation as you're trying to either build or grow your controlled substance drug diversion prevention program. We have the increased burden on medical and healthcare staff to monitor and witness the waste. These are all the audits. These are all the analytics. This is the workforce time it takes just to make sure we're compliant. There's definitely a cost associated with that. That includes costs incurred by the pharmacy to monitor all these waste-related activities, including drug disposal activities. And then finally, we have these costs that are very difficult to quantify. The costs associated with medication safety issues and errors, the costs associated with harm to patients who aren't having their pain or whatever adequately controlled, the costs associated with litigation or with loss of reputation. There's so much to this. It all adds up, though, to making sure that we have comprehensive drug diversion prevention programs in place. So with that, moving on to the next slide, I do want to leave you all with a few key takeaways. First and foremost, drug diversion is expensive. It results in societal, human, and financial costs, which I think Sue did a really nice job going over, and hopefully I helped reinforce this part of my conversation with you all. And controlled substance waste is significant, particularly when we're looking at areas of high use. I talk about the ORs and procedural areas, but there are others as well. And it's not just about the drug. It's not just about the product, but it's also about how are we making the best use of our incredibly valuable workforce. We need to be positioning them well, especially in times of constraint. And we need to be thinking about the other holistic costs like drug disposal that contribute to draining our healthcare dollars. And that's that last point here. Consider the total cost of delivering safe IV therapy. There's lots of great evidence out there. I highlighted my own work, but there is also a plethora of other evidence that can be used to guide the implementation of a great diversion and waste reduction program. Because if we do that, we're going to have an improved patient experience. We're going to prioritize our valuable health professional time, all the while ensuring patient safety and establishing a compliant practice. So with that, I truly appreciate your time and attention. And I know we've left a few minutes here to address any questions that you may have. Thank you very much.
Well, thank you so much, Susan and John, for sharing your knowledge with us this afternoon. I would like to remind participants you can ask a question by either typing it into the Q&A or the chat box. We do have a couple questions in our Q&A box, and I'm going to address the first one to you, John. John, in your study, did you take notice, was it policy to waste the overage of the medication prior to administration or after?
Yeah, thank you for that question. And in the organization that we studied, and it was two different hospitals, neither one had a policy that addressed that specific issue. And so there was a mix in practice. I'll also add to that, I know this wasn't what was asked, but when we did our time and motion study and when we quantified the costs associated with the workforce time, we only tracked the time to the ADC where the waste was occurring. So like a one-way pathway. We didn't then quantify the time having to leave and then go on to whatever else was next on that task list. So our workforce time waste measured and the cost associated, which was probably conservative because we only looked at a one-way path, not leaving that ADC as well as part of the process.
Great, thanks for that clarification. I have another question. I'd like to address this one to Sue. Sue, in light of a lot of the staffing shortages that we've been experiencing and drug shortages, and also with the knowledge that there are some situations where there might not be a pharmacy or a pharmacist available, can you comment on some risk mitigation strategies when sterile compounding might have to occur outside of a controlled environment like a pharmacy?
Yeah, sure, Chris, and you're right about that. You know, we deal with that currently, and we probably will for the future. Certainly, we want to make sure whenever there's not the pharmacist available or the technology available, that we're maximizing the use of those manufactured prepared products as much as possible, and trying to get those products in patient-specific doses that are ready to administer. But again, if those aren't available, we want to look carefully at what's happening with the compounding. So even the dilution and reconstitution, we want to make sure that we're following proper aseptic techniques, that we've got defined policies and procedures, and are following USP standards for beyond use dating and other regulations that are required. We also want to make sure that we have good labeling practices associated with that compounding. And we also would suggest too that you should have a second practitioner who's independently verifying any of those medications and diluents that are being added together. And we suggest that you confirm those ingredients along with the proper volume ahead of their addition into the final container. But certainly, that takes a lot of workforce, as you mentioned too, but you could investigate the ability to have pharmacists perform this verification remotely if you can use some video or still images. So certainly if it occurs outside the pharmacy, any of the staff who prepare or verify those compounded sterile preparations should be trained, and their competency to perform the sterile compounding and associated procedures should be assessed annually. So I know that's a lot, but we want to make the standard such that it's no different, for when those things are occurring off hours. It's important that we keep some of those standards.
Yeah, great food for thought for everybody. Good strategies. Thanks for that, Sue. I would like to again thank Susan and John for sharing their knowledge with us today. And ISMP would like to extend our sincere gratitude to Fresenius Kabi for supporting this program. All of you listeners, please do join us for the final program in this series. It's going to be on April 28th. Dr. Ryan Holmeschild and Dr. Ed Pollack will discuss engaging the OR and procedural areas to mitigate risks with controlled substance medications. Go to ismp.org to register for that program. And last but certainly not least, thank you, our participants, for joining us today. We do hope to see you next time. This concludes our webinar.